Hi, and in this lecture, I'm going to be discussing the role of screening in public health practice. So first we need to define what screening is. So the use of screening is to really identify a disease at an earlier stage. And the official definition is the presumptive identification of an unrecognized disease or defect by the application of tests, examinations, or other procedures. And a screening does not diagnose somebody with a disease. What it does is it takes people who have yet to have clinical signs or symptoms and classify them as either likely or unlikely to have that disease. And after they are screened, if they are screened positive, they would then go for follow-up diagnostic testing. And the purpose of screening is to either delay the onset of symptoms um, and hopefully to improve survival so that individuals can live longer. It's a type of secondary prevention in that the individual already has the disease, it's just preclinical disease. So we're just finding it sooner. It does not prevent the onset of disease in most cases. And it seems like screening should be fairly simple. You go, you get your blood pressure tested. What's the harm? But there's much discussion going on today about the role of screening and whether or not individuals should be screened because it can create morbidity, it can create illness in some cases, and in situations, for example, for cancer, it can create a significant amount of anxiety as well. And so there are certain criteria that need to be met in order for a screening test and a screening program to be considered successful. So you need a suitable disease. Not every disease is suitable for screening. So some diseases do not have a long enough preclinical phase, that latent period we had spoken about. You need to have a suitable test. So is the test good enough? Is it doing what it should do? Are we finding people at a point at which it's truly having an impact on the disease course? You need to have a suitable screening program. Who's getting screened? When are they getting screened? What's the cost of that screening? And so what do we mean by a suitable disease? Well, a suitable disease has to have serious enough consequences. It needs to be progressive, meaning that it can get worse over time. There must be evidence that treating the illness at an earlier stage has an impact. So if we're just finding the disease earlier but we can't treat you, that's unethical. We're just telling you you have it longer. It's not actually helping you. And there have to be enough people who have the detectable preclinical phase so that we can actually find individuals. Otherwise, it's searching for a needle in a haystack, which really is not economically efficient. Thinking back to those policy issues, right? So we need to not only be equitable in terms of who's getting the treatment or who's getting the screening, but it needs to be efficient. And so historically, we've thought of some examples of suitable diseases as many types of cancer, breast, colon, cervical, as well as certain risk factors for heart disease. Hypertension is a good one. And we're going to come back to breast cancer and cancers in general because there is some controversy there now. So when we're talking about a suitable disease, we want to think about different points in the disease. We have the age of biological onset, the age where, or the point at which the disease is detectable by screening, the age at which symptoms would develop, and the age of death. So A to C, biological onset to symptoms developing, is what's considered the total preclinical phase. So in this case, it's 30 years. Whereas the detectable preclinical phase is that phase between B and C, from 45, say, to age 60. So while there's a total preclinical phase of 30 years, the detectable preclinical phase is really only 15, and it's at that point at which screening could have an impact. And the detectable preclinical phase varies with the test, the disease, and the individual. And when we talk about screening, we talk about lead time. And lead time is the amount of time by which the diagnosis is advanced as a result of a screening test. So in this case, it would be that same time, that B to C, 15 years potentially. So what makes something a suitable test? Well, it should be relatively inexpensive. Now, that's relative compared to treatment. It should be easy enough to administer. You want to cause minimal discomfort and minimal invasiveness. And it should have, and this is very important, high levels of both validity and reliability. So a valid test basically does what it's supposed to do. It classifies people with the preclinical disease as positive and people without preclinical disease as negative, as much as possible. No test is 100% valid. And it also should be reliable. So if the same person goes for the same test week 1, week 2, week 3, they should get the same result. Validity generally is more important than reliability, because if a test is not valid, it doesn't matter if it gives you the same wrong result over and over and over. So they're both important, but validity is slightly more important. Just a visual example, this test is reliable but not valid. So again, it's hitting the same point roughly over and over and over again, but it's not where you want to hit. That's not the target. This has both low reliability and low validity, so you're not hitting the bullseye and you're not hitting any one point consistently. This is not at all valid or reliable, so it's sort of going everywhere. And this is both valid and reliable. That's our goal. So there are two different ways to test validity. There's sensitivity, which is the ability to identify cases, so identify people who are positive as positive, and specificity, the ability to identify people who are negative as negative. And a valid test has both high sensitivity and specificity. And so here's an example of looking at sensitivity and specificity and how we look at this. So there was the breast cancer screening program. Women were assigned to either mammographic screening or regular usual care, breast self-exam. And then they followed them up and they had biopsies to confirm whether or not they had cancer. So in this case, 1,115 people were screened as positive, were told you may have breast cancer, of which 132 did. 63,695 women were told you do not have breast cancer, of which 63,650 did not have breast cancer. So in this case, and if you look down, there were 177 confirmed cases and 64,633 who did not have breast cancer at the end of the study. So sensitivity is out of the people who had breast cancer, how many were screened positive? 74% means we missed about 25%. Specificity is out of the people who do not have breast cancer, how many were screened negative? 98.5%. So this test has higher specificity than it does sensitivity. So screening was very good at picking out women who did not have cancer, but missed 25% of women who did have cancer. The criterion of positivity is going to impact your sensitivity and specificity. And what that means is, at what point in the test is the outcome considered positive? There's no black and white, absolute yes or no in many of these diseases. Right? So there's the clearly negative zone, the clearly positive zone, and then there's a bit of a gray zone in between where it can be open to interpretation. And so there's a little bit of trade-off that happens with sensitivity and specificity. So here's an example. We have diabetes. Let's say this is the range of your blood sugar. This is the normal range. This is the diabetic range, and you'll notice that they overlap. So criteria 1 for diabetes, Anything over 110 milligrams per deciliter of blood glucose is going to be considered diabetic, and anything below is considered normal. Or we could have criteria B and put the cutoff over here at 150. So let's say we use criteria A. You'll notice there's this tail that's been screened negative but has diabetes. And this little area up here that's screened positive but does not have diabetes. So let's say we have a way of ascertaining the actual truth. This is our screening test. Sorry, I went through that too quick. So in this case, we're very good at identifying everybody who has diabetes, right? So we're getting most of the people. So we have very high sensitivity. But we're also misdiagnosing a number of people who, in this curve, who are screened positive who do not have diabetes. So we have very high sensitivity, but we have fairly low specificity. If we use instead criteria B, now you have a larger population that's screened negative, but actually has the disease, and very few people who are screened positive, but do not have diabetes. Meaning, you have a much higher specificity, but lower sensitivity. So what are the trade-offs? For criteria A, it's better sensitivity. B has better specificity. So there is this trade-off. But the question comes, why does that matter? Which one would you pick? Well, you have to think about how we're treating the diseases. Are we treating people, if we use criteria A, you're going to have a number of people who do not have the disease but are going to be treated for it. Now, if treatment means changing your diet, probably not a bad thing, going to have a positive impact in other ways. If treatment means you're treating them with medication, which could have potential negative side effects, do you still want to use criteria A or do you want to use criteria B? And does it matter if you're missing people or not? So there are trade-offs. Then we have to think about the screening program, right? So what population are you looking to screen? Is it for everybody? And does everybody include children, adults? What age group? At what point does it make the most sense to screen individuals? And so you have to determine a few things for a program to be successful. One is, does it actually reduce long-term morbidity and mortality? And when you're reading the articles, you'll see, for this particular section, you'll see that there's a debate about the difference between reducing disease-specific mortality and reducing overall mortality. So the idea that screening saves lives is really being debated in what that means and how we move forward with our screening programs. But the two ways that we tend to evaluate screening programs are called feasibility and effectiveness. So feasibility is the test acceptable? Will people actually be screened? So you think about something like colon cancer screening with colonoscopy. It's very difficult, or historically was very difficult, to get people to go in for a colonoscopy. The prep for a colonoscopy is uncomfortable, and the procedure itself is something that people tend to cringe about, right? So you're having, a camera inserted into your rectum, up through your colon. People tend to be uncomfortable with that. Has relatively considerably, considered compared to other screening, like a blood pressure cuff, it seems to be less acceptable because it's more invasive. So getting people to actually get screened can be more difficult. Again, we mentioned the cost, which has to go back to those issues of, is it efficient? And then looking at feasibility about the predictive value of a positive test and the predictive value of a negative test. So the predictive value of a positive test says that of the people who screen positive, how many actually have the outcome? And the negative predictive value is of the people who screen negative, how many people really don't have the outcome? So going back to our breast cancer screening program, now instead of looking down the columns, we're going to be looking across the rows. So of the people who were screened positive, how many actually had the disease? So your positive predictive value is 132 out of 1,115, or just under 12%, compared for our negative predictive value of the 63,000, almost 700, who were screened negative. 63,650 did not have the disease. So your negative predictive value, or the predictive value of a negative test, is 99.9%. So in this case, mammograms were showed to be very good at identifying people who did not have breast cancer, but were also not as good at picking out people who really did have breast cancer. So we know that the predictive value will increase when sensitivity, specificity, and disease prevalence increase. So if we have better sensitivity, better specificity, and a larger number of people with the disease, your predictive values will be better. So for example, your positive predictive value will increase if you perform breast cancer screening on a higher risk population, for example, older women and those with a strong family history of breast cancer. And that's part of what has been the ongoing controversy around breast cancer screening. So the guidelines have been getting for who should be screened have been changing. They've been moving towards older women and women with a very strong history, and that's caused a lot of controversy because it is true that women under 45 can get breast cancer and can get deadly breast cancer. And so if the guidelines are saying you don't really need your first mammogram until you're 45, and after 55 you can move to every 2 years, that's based on the evaluation of screening programs with predictive values. But that is at a population level, right, where we're talking public health, whereas an individual level, that may not ring true. And the reason why all of that is important is because when we use these data to inform, to evaluate screening programs, this data goes back and influences health policy. So if we go back to the last section of the course, we're talking about what do we cover and when, right? So funding every screening program is expensive. So if we're going to expand our health insurance coverage and we're going to make preventive screening free with your insurance so there's no cost sharing, it may be that we need to limit who gets screened. So to increase efficiency, we may need to decrease equity. So let's look at how prevalence impacts your predictive value. So let's have a test that's really good. It's a good test. It has 99% sensitivity, 99% specificity. And we're going to look in two different populations. Population has a low prevalence of the disease, only 1 out of every 1,000. So if you have one individual out of every 1,000, and just trust me on the numbers, you're going to end up screening with 99% sensitivity and 99% specificity. You're going to get 2 positive results. One will be a true positive, one will be a test error, meaning your predictive value, your positive predictive value will be 50%. Got a 50-50 chance if you're screened positive of actually having that disease. Right, so this is 1,000 people, one has the disease, somebody else was screened as positive but they don't have the disease. So you've got a 50-50 chance of finding the right person with that particular screening test. Now we're going to take that same test and we're going to apply it to a population that has a higher prevalence of the disease, 10. So looking at that same disease, we're now going to be able to identify 11 positive test results, of which, since the prevalence is 10, 10 will be true positives and 1 will be a test error. So now your positive predictive value goes up dramatically from 50% to 90.9%. So here are all the people with the disease. and we're going to get one test error, meaning we're doing a pretty good job. So it's really important when we think about who should be screened, thinking about the high prevalence population. So going back to that breast cancer example, it's been shown that because as we age, the prevalence of breast cancer increases, that testing at slightly older ages increases the prevalence of the disease, meaning that we're better at catching it. We're going to have fewer test errors if we're in a high-risk group, which is why the current guidelines say 45 and older, or women who have a strong family history. That being said, if we're not screening in a lower risk population, sorry, there we are, too far. If we're not screening in this population, right, so say this is women 35 to 45, and there's only going to be one case, if we're not screening in this population, then this one case won't be found until they're 45. And the question is, does that have an impact on this individual's life expectancy, life quality, disease progress, etc.? And that's where the controversy comes in. So we also have to consider different biases that come into play when we're evaluating a screening program. And the biases can result when we're looking at the test, and it's going to impact its efficacy. And so these are volunteer bias, lead time bias, and length biased sampling. So volunteer bias basically states that individuals who participate in a screening program may either be healthier, so your healthcare junkies, people who are into health and wellness and therefore they probably don't have the disease because simply the way that they're living their lives, or people who are at higher risk of developing the disease because they recognize they're more at risk, so they're more vigilant. And so you need to know who's in your population, right? And that can bias it in either of two ways. There's also something called lead time bias. And so lead time bias basically says we're advancing the time at which we diagnose the disease, but are we really extending their lives? So if we're going to go back to our hypothetical, we had our biological onset, one it's detectable by screening, and then death. So woman X is diagnosed at screening at age 41. Woman Y is diagnosed at age 43 when symptoms would naturally develop, the natural course of the disease, and they both die when they're 46 years old. So here the survival time for woman Y is 3 years. The survival time for woman X is 5 years. But they both died at the same age. All we did was advance the diagnosis by 2 years. So lead time bias makes it look as though woman X survived 2 years longer, when in reality we didn't actually change that. What we would want to see is woman X not living to 46, but living well beyond 46. And then length bias sampling, which basically is the idea that screening, in this case particularly cancer screenings, are much, much better at finding less aggressive forms of the disease because they have a longer detectable preclinical phase. More aggressive diseases, that preclinical phase is shorter and survival is shorter anyway. And less aggressive forms of the disease tend to have better survival anyway. So finding them earlier isn't, again, necessarily extending the disease process or your survival. So let's say we have a program, it's administered to 5 different people for screening at this particular point in time. And this is the detectable preclinical phase or the survival time, however you look at it. Detectable preclinical phase for each individual. So who's going to be picked up at screening really depends on the time of the screening as well as the disease. So these 2 individuals who clearly have more aggressive forms of the disease aren't going to get picked up by screening, right? They have a lower chance. Individuals have a less aggressive form of the disease with a longer detectable preclinical phase are more likely to be picked up. And again, right, we know right now is mammograms are much better at picking up less aggressive forms of the disease. Does this mean we do away with mammograms and say forget it? No, it's good for what it does, but I would put out there that what we need now is research, and this is going on how to improve mammography or find other screening tests for those more aggressive forms of cancer. And digital breast exams or digital mammography is really seeking to do that. So, a summary of screening is the presumptive identification of unrecognized disease using tests, exams, etc. A suitable disease must be serious with important consequences and it has to be progressive. So, we're not going to screen for the common cold. It's not serious, tends not to have important consequences, it is not progressive. Get it, you survive, you recover. 7 days. A suitable test has to have relatively low cost, has to be acceptable, and it has to have a high degree of validity, which is measured by sensitivity and specificity. And screening programs have to administer those tests to high-risk populations. And we evaluate whether a program is effective and efficient by looking at the predictive value, both positive and negative, and outcome measures such as stage distribution, cause-specific mortality, and now total overall mortality. And when we're looking at the evaluation of these screening programs, we have to consider things like bias, whether it be lead time bias, length bias sampling, or volunteer bias. And so for the discussion for this lecture, you should have listened to this, read the articles on cancer screening, and I want to know what your take-home message is that you're walking away with. When we're talking about cancer screenings, what are your impressions of the current recommendations? Do you agree with them? Why or why not? And do you think these articles clarify the need for screening, or do they make the issue less clear for you? Did they change what you thought you knew?